We'll come back to the complete story 6. Today we'll talk about very important topic, and really we'll talk it about a lot in our series of complete story, which is the value of critical care ultrasound in shock. Remember, shock is a dynamic state and need investigation which is dynamic. Yes, sure, it is a critical care ultrasound. I was asked to see a 47 years old patient in ER who is known case of chronic renal failure on dialysis through permicast. He has ischemic cardiomyopathy AF on anti-failure medication and warfarin, who came because of acute abdomen and he was shocked, blood pressure 70/50 on levofed 20 mg per minute. As you see here, the patient is ischemic cardiomyopathy AF, chronic renal failure, and develop acute abdomen. A lot of differential diagnosis as regard the acute abdomen you can think about here. Any surgical cause like perforated viscus, ischemic bowel, congestive liver due to heart failure, long list of differential diagnosis, and not only the diagnostic dilemma but also the therapy. Can I give now IV fluids? Is it better to give inotrope like dobutamine or inopressor like levofed? A lot of questions you need to answer now in this critically ill patient. We did X-ray chest for the patient. As you see, there is permicast here in place. There is some opacities here, infiltrate here in the right lower lung zone with heaviness of the right cubital diaphragm, denoting some inflammatory process in the right lower lung zone. There is hilar congestion. There is loss of volume of left lower lobe. As regards the abdomen, there is no air fluid level and no air under diaphragm. As regards the abdomen, it's not conclusive. We will start now to see the value of critical care ultrasound in this shocked patient. Usually, I start assessing the shocked patient by ultrasound by assessing the inferior vena cava to know about the volume status. Here is the inferior vena cava of the patient. It is collapsing more than 50%. In this patient with chronic renal failure and ischemic dilated cardiomyopathy AF, I expect to see full non-collapsing inferior cava. To see this collapsing inferior vena cava in this patient, sure, there is dehydration element. So we have a hypovolemic element and we have cardiogenic element. After that, after assessing the inferior vena cava, I usually go to the heart. For this patient with ischemic dilated cardiomyopathy, we need to see what's going on. This is the parasternal long axis view, hypokinetic septum, hypokinetic posterior wall, calcification posterior leaflet of the mitral valve. This is the short axis view, hypokinesia all over. With visual assessment, you can say it is almost 20% ejection fraction. So we have a hypovolemic element because inferior vena cava is collapsing, and we have cardiogenic element of ischemic dilated cardiomyopathy in this patient. After that, usually I need to go to the chest to be sure the lung is dry in this cardiogenic patient. As you see here, all A lines, no B lines all over the lung field, denoting this patient is on the dry side and no element of pulmonary congestion, as evidenced by B line, which is not present here in this patient. After that, we now have a patient with dry lung, hypovolemic, cardiogenic ischemic dilated cardiomyopathy, and complaint of acute abdomen. Acute abdomen. Now we'll go to the abdomen by critical care ultrasound and know how can ultrasound tell us and how can benefit us in this acute abdominal state. Yes, as you see here, this is the right cupula of the diaphragm, this is the liver, and up here is the right lower lung zone. You see definite, there is fluid, anechoic fluids here with echoes inside just below diaphragm and above the liver, denoting dirty fluids under diaphragm, which is collection. And up here you will see pleural effusion and atelectasis. This is the area we see in the X-ray in the right lower lobe, which there is infiltrate and heaviness of the right cupula. Here it's very clear. We know now what is going on. There is fluids under diaphragm, which is dirty, subdiaphragmatic collection, and here there is right side pleural effusion and atelectasis. Yes, very, very, very beneficial information. Very, very important piece of information in very sensitive and critical time. In critical time, you get a very valuable information in this patient. Moreover, we look for the pelvic for this patient, and we found also the dirty fluids in the pelvis. So, our patient here has inflammatory process in the abdomen, intraperitoneal. Moreover, the liver, as you see here, is coarse liver, and there is atrophic kidney, echogenic kidney, small sized kidney compared to the liver. You see here, the liver is hypoechoic, while kidney hyperechoic because it is echogenic kidney and advanced grade of nephropathy. Irregular surface of the liver, irregular surface with coarse liver. Probably this coarse liver due to most probably element of cardiac cirrhosis because of heart failure. Fitting the puzzle together after couple of minutes, we know now there is bad heart as evidenced by bad ejection fraction. We have a dry patient, dry lung, we have chronic renal failure, and there is dirty fluid intraperitoneal, pelvic, or subdiaphragmatic. It is very, very, very valuable information in no time. What do I need to do now? Giving controlled targeted IV fluids, urgent surgical consultation. This is very important. You hear from me here always in the complete story series, the controlled targeted IV fluids, the proper IV fluids for the shocked patient. In shocked patient, we will give IV fluid as long as we are get benefit from these IV fluids. The IV fluid giving will be targeted by the VTI, which is the representative of the stroke volume. I will give IV fluid as long as the VTI is increasing by 12%, which denote it is the IV fluid is doing its job by increasing the stroke volume. And I will control IV fluids to not lead to pulmonary edema by following the lung water, and I will stop before B line appear in the lung. We will see here within minutes. As you see here, before giving IV fluids, I used to get this 5-chamber view, and I will put sample volume of pulsed wave Doppler here in the left ventricular outflow tract to get the pulsed wave of the left ventricular outflow tract VTI, which is very important. This is a VTI. This is the Doppler of blood coming out of left ventricular outflow tract, coming away from the probe, so appear below the baseline, and you see here VTI is variable because there's AF, so I get more than one. One is 15 and one is 13, and I will get the average of this VTI. Once I get the average, I will start to give boluses of IV fluids. As long as the average of VTI is increasing by 12%, I will keep giving IV fluids. That means I am still in the ascending limb of Starling curve, giving IV fluids and increasing stroke volume. If I give fluids and stroke volume and VTI is not increasing by 12%, that means, yes, it is finished. This IV fluid should be stopped now because it's not doing the job and increases stroke volume. Always you will hear from me this way of giving IV fluid, which is targeted IV fluids. I give 500 normal saline, 250 ppf, which is human album 5%, which is good amount really in patients with chronic renal failure and ischemic dilated cardiomyopathy. Let us see, after giving this good amount of IV fluids, as you see here, inferior vena cava is still collapsing. It's not opened up, it's not filled up. Lung water, still A lines all over. No B lines appear, that means the lung is still dry. More important, look carefully for this image. This is the VTI of the patient before, and this is the VTI after IV fluids. Almost the same, no increase by 12%. It's very, very strange for this patient. For this patient with chronic renal failure and ischemic dilated cardiomyopathy and AF, and I give 500 normal saline, 250 ppf colloids, and at the same time, no increase in the VTI, no increase in the diameter, and decrease the cholesterol of inferior cava. It's very, very strange. But I saw this scenario twice this week. Because of that, I need you to get this very, very important piece of information. if you're shocked patient, if in your shocked patient you give good amount of the fluids and you didn't get the response of these fluids as evidenced by increased VTI and inferior vena cava and the lung is still dry, that means your patient is losing the fluid you give. Please, please, please think of the blood loss. I saw this scenario twice this week. Think of blood loss, especially in the GIT. Shortly after our patient passed large amount of coffee ground on the NGT, INR came out of range. So, at the moment, refitting the bottle, at this moment, we are talking now about minutes, very short time. We get a lot of information. As you will hear from me always, a lot in one shot. A lot of information you will get by a shot of ultrasound probe. It is amazing, really, in shock. In shock patient, critical ultrasound is amazing. At the moment, let us refit the puzzle together. Bad heart, dry patient, chronic renal failure, and giving fluid not responding. So, patient is septic and dirty fluids in the peritoneum. Septic and hemorrhagic and cardiogenic shock. Septic and hemorrhagic due to most probably perforated viscous, cardiogenic because the baseline of the patient, which is ischemic dilated cardiomyopathy. You diagnose 3 major type of shock within minutes by this amazing ultrasound machine. Surgical team ask about CT. Definite, yes, sure. There is fluid around the liver and below the diaphragm. There is air here below the diaphragm. So the picture now is very clear, very clear. It is perforated peptic ulcer, lead to septic and hemorrhagic shock from bleeding in patient with ischemic dilated cardiomyopathy and chronic renal failure. What need to, because the diagnosis, as you see now, is complete and full picture is appear in front of us now. Treatment is straightforward. Yes, we need a lot of hematological support, packed red blood cell, fresh frozen plasma, and urgent damage control surgery for this patient to save life of this patient. And at the end, I need to thank this beauty ultrasound machine, and thank you for appreciated listening, and see you in the complete story 7 recently, inshallah. Bye bye. Thank you.